My name is Dr. J.Nichols, a pediatric anesthesiologist, and I will present this podcast on the management of patients with sternal malformations based on an educational review article written with Dr. Vivian Nasr, published in Pediatric Anesthesia. So first off, sternal malformations are a rare set of anomalies that range from readily repairable sternal clefts to inoperable cervical ectopia cordis. It's critical to understand the myriad of possible coexisting congenital cardiac and non-cardiac defects, and also the hemodynamic effects of compression of the heart and great vessels that may be caused by the surgical repair itself. Given the rare occurrence of sternal malformations, surgical repair should be undertaken at centers with vast experience and where the full armamentarium of pediatric specialists is available for pre- and post-operative care. So a little bit about history. The first documentation of congenital sternal anomalies dates back to the cuneiform tablets from the Royal Library of Nineveh, and the first attempt to classify the subtypes of sternal malformations was by Weiss in 1818. Subsequent classification schemes were developed by multiple authors, but a definitive nomenclature remained elusive until 1990 when Schamberger and Welsh classified sternal malformations based on tissue coverage of the heart, and they classified them into four types of sternal defects: thoracic ectopia cordis, cervical ectopia cordis, thoraco-abdominal ectopia cordis, and a simple cleft sternum. Of the four subtypes of sternal malformations, simple cleft sternums are the most common subset, with a reported incidence of 1 in 50,000 to 100,000 live births. A. Costello et al. Further classified cleft sternums into complete or partial, and the partial cleft can be either superior, medial, or inferior. The simple superior partial cleft sternum is by far the most common, with an orthotopic heart, intact pericardium, and normal skin coverage. Associated anomalies with superior partial cleft sternum are rare, but can include cervicofacial hemangiomas, a midline raphe from the tip of the cleft to the umbilicus, and Facies syndrome. The much more rare inferior partial cleft is associated with thoraco-abdominal ectopia cordis as part of the pentalogy of Cantrell. Now that we've talked a bit about the history and the epidemiology, let's discuss a bit about embryology. So the embryologic origin of sternal malformations remains an active area of investigation. Simple partial sternal clefts develop from malunion of the manubrium, with the lateral pull from the ribs and thoracic musculature magnifying the U shape of the cleft. In cleft sterni, there is a female predominance, a connection to impairment in HOX-B gene expression, and also a relationship to acute excessive alcohol consumption during pregnancy. In contrast, the three types of ectopia cordis show a very weak association with trisomy 18, triploidy in general, and an X-linked inheritance pattern. It is thought that cervical ectopia cordis is due to failure of the heart to descend into the thorax during the third week of gestation. Additionally, it is thought that thoracic ectopia cordis is secondary to rupture of the yolk sac or the chorion, causing mechanical compression and interference with cardiac descent. And finally, it's thought that thoraco-abdominal ectopia cordis is due to tethering of the heart by para-umbilical bands. So now that we've talked about epidemiology, let's talk a bit about presentation. Cleft sternum is generally a postnatal diagnosis with characteristic bulging of the mediastinal viscera through the sternal defect, especially with crying or coughing. Children are generally asymptomatic, and they present for closure within the first 3 to 5 months of life for both cosmetic and protective reasons. Thoracic, cervical, and thoraco-abdominal ectopia cordis are most commonly discovered ultrasonographically at the beginning of the second trimester, and birth is safest via cesarean section to prevent trauma to the extracorporeal thoracic and abdominal structures. Ectopia cordis cases are neonatal emergencies with likely immediate endotracheal intubation and resuscitation, followed by the different stages of operative repair over the first few weeks of life. Now that we've talked about the presentation, let's talk about the specific anesthetic and surgical management of these patients. So, of note, the rate of successful repair of sternal malformations is inversely related to the severity of the defect. And given their rarity, reports of repairs are limited to short case series. In general, repair of a cleft sternum is universally successful, while repair of cervical ectopia cordis is not attempted due to the fact that the heart cannot be returned to the thoracic cavity without severe derangement of cardiac function. Thoracic and thoracoabdominal ectopia cordis repairs have varying levels of success, primarily dependent on whether the heart is partially or completely outside of the thoracic cavity, as shown in the most recent case series describing the experiences from Boston Children's Hospital and UCSF Bainoff Children's Hospital from 1995 to 2014. So let's start with a discussion of the repair of a simple cleft sternum. So sternal cleft repair is preferentially performed in the first 5 months of life, given the flexibility of the cartilaginous sternum and ribs, which allows for primary approximation of the sternal bars. Later repairs may require sternoclavicular disarticulation, sternal isolation, inferior sternal osteotomy, medialization of the neck muscles, use of prosthetic materials, or even partial thymectomy, all of which greatly increase the risk of the surgery itself. The aim of the surgery is to restore the protective role of the sternum and mediastinum, to prevent paradoxical lung and cardiac movements, and to allow for normal thoracic growth. Intraoperatively, after midline incision, blunt dissection of the sternal bars from the endothoracic fascia is performed with great care so as not to injure the heart or the great vessels. After freeing the sternal bars, they are approximated with non-absorbable suture. A wedge osteotomy at the inferior portion of the sternal defect can aid in approximation. Given the non-hypoplastic thoracic cavity, existing soft tissue coverage of the heart, and rare underlying congenital cardiac defects, these repairs are often well tolerated, with primary concern being undue compression of the heart and great vessels at the time of closure. From an anesthetic perspective, infants with sternal clefts are remarkably stable preoperatively, and after a full workup to ensure no associated cardiac, abdominal, or craniofacial abnormalities, they should be evaluated in the days preceding the planned cleft closure to ensure no acute illnesses similar to any other surgical candidate. Notably, if a child becomes agitated or cries, the great vessels in the mediastinum tend to protrude through the sternal defect, and while alarming visually, it is generally well tolerated by the child. A supraumbilical raphe is also common to these children and is not a cause for further workup or concern. Standard day of surgery preoperative management is the norm in these children, followed by a pre-anesthetic evaluation, and then the patient can safely be given a preoperative anxiolytic and transported to the operating room uneventfully. A preoperative intravenous catheter and invasive hemodynamic monitoring are not necessary in these cases. Next, an inhaled or intravenous induction can proceed in the standard fashion, followed by endotracheal intubation. Placement of a large bore intravenous catheter and access to autologous packed red blood cells are recommended given possible, though unlikely, injury to the great vessels during surgical dissection or closure. An arterial catheter is also recommended, given the desire to closely monitor the hemodynamic effects of sternal closure and potential compression of the great vessels. It is customary at our institution to place a high thoracic epidural catheter for postoperative analgesia, which can be placed both either preoperatively or postoperatively. The greatest intraoperative concerns are vessel injury during sternal dissection, and obstruction of the great vessels, and elevated intrathoracic pressure following sternal approximation. Assuming no hemodynamic or ventilatory compromise following sternal closure, endotracheal extubation in the operating room is reasonable. Following close monitoring and careful titration of epidural local anesthetics and potentially intravenous opiates, transport to the intensive care unit is recommended for close monitoring of respiratory status and cardiac function. If there are no concerns at that time, transfer to the general surgical floor is reasonable on postoperative day 1. Next, I'll describe the management of thoracic ectopia cordis and thoracoabdominal ectopia cordis. The diagnosis of these very rare conditions is often made ultrasonographically at the beginning of the second trimester, with MRI used to further elucidate the likely multiple congenital anomalies. The child is often born via cesarean section, as vaginal birth might be too traumatic to the heart and other ectopically placed structures. True, complete thoracic ectopia cordis is almost universally fatal, while thoracoabdominal ectopia cordis has approximately a 50% survival rate. Both types of ectopia cordis are neonatal emergencies, and the order of interventions is divided into 2 stages. The first stage includes post-birth resuscitation, elective endotracheal intubation, potentially under placental circulation, the temporary covering of anterior defects with sterile gauze, and hemodynamic stabilization. Following stabilization, the second stages can include chest and or abdominal wall reconstruction with primary closure, split thickness skin grafting, cadaveric skin grafting, or prosthetic material covering, followed by subsequent slow reduction of the heart into the thoracic cavity over time. In all cases, a difficult intubation may be encountered due to the anterior encephalad position of the heart, and pulmonary hyperplasia and resultant respiratory distress are common secondary to thoracic hypoplasia. Replacement of the heart and great vessels into the thorax may be limited by thoracic hypoplasia and hemodynamically significant compression of the heart and great vessels. Partial or total excision of the thymus, diaphragmatic repair, costal cartilage division, and left lower lobe lobectomy have all been utilized to create space in the thoracic cavity in an attempt to avoid the compressive effects of placing the heart in the hypoplastic cavity. Of note, in thoracic ectopia cordis, it is generally best to build the anterior thorax out around the heart rather than place the heart back into the thoracic cavity, as compression of the heart is not well tolerated in these children. The unique complexity of these exceedingly rare neonatal emergencies and the frequently associated intrinsic cardiac anomalies necessitates a comprehensive preoperative evaluation involving the surgical, medical, anesthesia, and obstetric teams. A full understanding of all congenital anomalies is required, and the multidisciplinary team must agree upon the order of any additional diagnostic studies and repair of the defects. If emergent endotracheal intubation is required, discussion should be made with the obstetric team as to the feasibility of intubating while still under placental circulation, especially in the rare cases associated with endobronchial hemangiomas. Following likely endotracheal intubation at birth, peripheral intravenous, intraarterial, and central venous access will need to be obtained for hemodynamic monitoring, resuscitation, and potential cardiopulmonary bypass. Autologous blood should be immediately available, and initial concerns will involve fluid losses secondary to exposed tissue, organ damage from birth or postnatal exposure, and any intrinsic life-threatening cardiac or pulmonary defects. Following initial stabilization, the focus will be to repair known defects prior to sternal closure. Given the potential multiple procedures and intrathoracic repairs, sternal closure is often delayed in these patients. Concerns during repair will be ongoing fluid losses, increased intra-abdominal and intrathoracic pressure from attempted internalization of ectopic structures, and cardiac collapse from pressure on the great vessels and chambers of the heart during cardiac manipulation. Postoperative analgesia does not typically include an epidural, and the patient remains intubated given the complexities of the surgery and tenuous recovery. The patient will remain intubated postoperatively and should be carefully transported under full monitors to the intensive care unit for postoperative care. A prolonged stay in the ICU should be expected, given the likely need for multiple operative interventions. We hope that this podcast provides a comprehensive summary of the perioperative management of sternal malformations. Please see the full manuscript in Pediatric Anesthesia for further details and illustrations.